Welcome, everyone. I see everybody's pouring in, and I'm just giving everyone a few minutes to get into the virtual room. I'd like to welcome everyone to the Ontario NEIHR Indigenous Suicide Risk Assessment session that's presenting key findings and new directions by Dr. Jeffrey Ansloos and his research team of Jordan McVittie, Shanna, Peltier, and Nicole Santos Dunn. We're just going to wait a few minutes because there's actually a lot of people still coming in. So we want to make sure everybody's in before we start. But welcome, everyone. It's very exciting to see the names of everyone coming in, and it's a real thrill to have you all here on this beautiful Friday. Here in Toronto, we have cold air and blustery winds and a lot of snow. And but it's a beautiful winter day, and I'm very grateful to be here sharing the space with everyone. Let's see. I'm also going to draw your attention to something that's been posted in the chat, which is a feedback survey for all of you to take at the end of the session, just to give us feedback for the presenters so that they can see what their strengths were. Sorry, the dog's drinking out of her water. It's the wrong moment. So we can get hear the strengths and to continue to improve our presentations to meet all of your needs. So without further ado, we're going to start our presentation. My name is Suzanne Stewart. I'm from the Yellowknife Dene First Nation in the Northwest Territories, and I'm a professor at the Dahlana School of Public Health, where I'm the director of the Waakabenez Bryce Institute for Indigenous Health Research, as well as a member of the Ontario Network for Environments for Indigenous Health Research, along with Jeffrey Ansloos and a whole slew of other wonderful researchers, elders, community members, and community partners. So on behalf of this wonderful research network, we'd like to welcome you to one of our theme groups within the research network is doing their work around Indigenous suicide. And so Dr. Ansloos is going to share his current study around that right now. So I will invite Dr. Ansloos and his team to introduce themselves as they get started. So miigwech everyone for being here, and thank you, Dr. Ansloos and team for making the time to share this wonderful information with us today.
Well, good afternoon, everybody. It's a pleasure to be here with you, Tanse, Bojo, Amin, Sego. It's really great to present to this network. We feel always right at home here. I'm going to just introduce myself briefly, and then Jordan, Shanna, and Nicole can introduce themselves as well. But as Suzanne said, my name is Jeffrey Ansloos. I'm a professor at the Ontario Institute for Study and Education, where I work with these amazing students that you're going to get to meet today. My family comes from Fisher River Cree Nation. I grew up in Winnipeg, but I now call Toronto home. And yeah, we're really excited to share this work with you today. Really a work in progress and a puzzle piece of a much larger group of projects that are all embedded within the Indigenous suicide prevention and complex crisis response theme of our NEIHR. Jordan, why don't you introduce yourself next?
Hi everyone, my name is Jordan McVittie, and I'm a first-year PhD student in the School and Clinical Child Psychology program at OISE, U of T. I am from New Liskeard, Ontario, which is about 5 hours north of Toronto, and I'm a proud Anishinaabe Kwe from Temiskaming First Nation. I am in Dr. Ansloos's Critical Health and Social Actions Lab, where my research looks at Indigenous child suicide in Canada. And I'm really excited to be able to talk to you about some of our findings around Indigenous suicide risk assessment today.
Excellent. I'll jump right in after you, Jordan. So hi, Ani, everybody. My name is Shanna Peltier. I'm an Anishinaabe from Mukwamukong unceded territory. I'm also a doctoral student in school and clinical child psychology at OISE, working with Dr. Ansloos here in the critical health and social action labs while we're all stumbling here in the beginning. But my research really focuses on complex crisis response, specifically looking at suicide and preventing suicide within Indigenous community contexts. And I'm also excited to be here today. Thank you.
All right. Hello, everyone, even though I can't see you, but I know you're there. My name is Nicole. I'm a white settler of Portuguese and Irish ancestry, and I grew up on the traditional lands of the Mississaugas in Whitby, Ontario, which is on the Williamson's treaties. I'm a third-year PhD student in clinical and counseling psychology at OISE, and I'm also supervised by Dr. Ansloos. My research interests look at the ecological dimensions of suicide, houselessness and housing insecurity, and the needs of young women and girls. I'm a psychotherapist, and I currently am completing a practicum at Native Child and Family Services Toronto. So really excited to be here and to talk with you with what the team has found.
Yeah, so we'll jump right in today. We're going to be sharing kind of the Zoom microphone. But today we're really sharing with you the results of a fairly brief scoping review. It is not a systematic review, meaning that we're not talking about everything of published literature on the topic, but we're talking within a range of more specific questions, really focused on the question of what's out there in the world today in terms of research and gray literature related to the practice of suicide risk assessment and the kind of broader practices that exist around it, and specifically risk assessment as conducted within the context of Indigenous communities. So we're going to present some key findings and some directions from that research. But before we get started, we want to just take a moment to acknowledge the various partners that are involved with this research. So as has already been mentioned, just want to highlight some of the other research assistants involved in this work: Stephanie, Sara, and Anik, who all work at the Critical Health and Social Action Labs at the University of Toronto, Ontario Institute for Studies in Education. Our work is also in this theme, the Suicide Prevention and Complex Crisis Response theme, in partnership with Shikabe Makwa and First Peoples Wellness Circle, with Dr. Renee Linklater and Dr. Brenda Restoule, who are both members of the NEIHR, and also to acknowledge that our work in the Network Environments for Indigenous Health Research is funded through the Canadian Institutes for Health Research. Over the course of our presentation today, we're going to highlight some of a number of different things. First, we want to introduce the goals of this literature review and the key methods engaged for reviewing, as the PowerPoint indicates, reviewing literature. And really then from there move into what the actual findings of this literature review were and some of the implications for future research and practice. So just to start off with the goals of this review, suicide is a very complex phenomenon that disproportionately impacts Indigenous peoples in Canada. And being able to assess for suicidal risk in both clinical and non-clinical contexts is widely regarded as an important element, an important component in the practice of suicide prevention. If we can better understand the reasons why suicide occurs, the risk factors that contribute to the development of more active forms of suicidality, and if we can learn to discern that in the context of engagement with people who might be suicidal, risk assessment is an important part of thinking about prevention. For those of you familiar with my scholarship, might be actually a bit more surprised to hear me talking about this topic today, but of course it's one piece of the puzzle. It doesn't reflect everything that's involved, and of course, as an aspect of suicide prevention work, risk assessment is in and of itself a fraught and problematic space as well, which you'll see today in our presentation. Our literature review really sought to understand the following things. What is the current health status and context of Indigenous peoples in relationship to suicide? What, if any, approaches to suicide risk assessment that exist for Indigenous communities are here in Canada and elsewhere around the world? And are these practices relevant and effective? So that's what we're going to share with you primarily today. And Jordan's going to talk to you now a little bit about how we developed this review.
Yeah, so we started a search for articles in June of last year using a wide range of databases. We identified 27 academic articles, in which 17 were deemed relevant for the purpose of our research. We also identified a handful of gray literature from community organizations. We noticed that most articles came from North America. However, we also downloaded several articles from other countries with experiences of settler colonialism, like Australia and New Zealand. We then completed extractions and summarized each of the articles. And following the creation of summaries, our team synthesized the information into the present literature review, which we'll be talking about today.
One thing I want to say before I forget, because I wrote it on that slide, is just that the following today's presentation in the next month, we're going to be publishing a briefing on the current state of Indigenous specific suicide risk assessment in partnership with KMH. So for those of you attending today who are hoping to get some actual really accessible resources related to the findings of this literature review, they will be made public, and we'll make sure to send it throughout and distribute throughout the attendees of today's webinar. Sorry to jump in on you there, Jordan.
Excellent. Okay, so I'm just going to do a little bit of an overview about Indigenous peoples in Canada and then bring us into some statistics and demographic information around suicide, Indigenous suicide here in Canada. So in 2016, more than 1.67 million individuals identified as an Indigenous person on the Canadian census. This equates to about 4.9% of the population of Canada. And so Indigenous people in Canada, there's 3 federally recognized groups here. There's First Nations people, Métis people, and Inuit people here in Canada. And Indigenous peoples overall in Canada are also identified as one of the fastest growing populations at a rate of 4 times more than non-Indigenous people. So as we keep that in mind, the number, the vastness of Indigenous peoples here in this country, and then also the fact that we are a very fast and rapidly growing population, when we begin to talk about suicide and responding to Indigenous suicide here in Canada, I think it's just important to keep that context in mind. And so suicide is it's frequently framed as a problem, quote unquote, within Indigenous communities in Canada. And most notably, it's frequently depicted through public discourse, mainstream media, as frequently portrayed as either a national crisis or a state of emergency, to which Canada is also known as home to the suicide capital of the world. Beginning with the release of Choosing Life, which was a special report on suicide among Aboriginal people, suicide was noted as being a rare choice made by elders within the context of specific family and community dynamics. And so proceeding to change with increasing numbers of Indigenous youth dying by suicide in Canada, RCAP hypothesized and outright warned that the number of suicides for Indigenous youth would actually rise over the next 10 to 15 years. And so the Choosing Life report was published in 1995. So it's been over 25 years that have come to pass with no alleviation to the suicide rates within Indigenous populations in Canada. And so just some statistical information, Indigenous peoples are reported to die by suicide at a rate of 3 to 5 times the national average in Canada. It has been estimated that in some communities, suicide rates for Indigenous youth under the age of 15 were 50 times higher than non-Indigenous rates. The gravity of this situation can really not be understated when it comes to suicide and self-injury, because they are noted as the leading causes of death among Indigenous youth and adults up to the age of 44 in Canada. In addition, rates of suicide increase for Inuit at 5 to 25 times the national average, to which at a rate of 11 times the national average, Inuit youth suicide rates are among the highest in the world. It has also been reported that 1 in 5 Métis individuals over the age of 18 have had suicidal thoughts in their lifetime. And unfortunately, there is currently no population health data for Métis young people or Métis youth. And this is really a problem and a marked invisibility within the literature for Métis young people here in this country. And I just want to recognize and sort of bring forth that I threw all of these stats at you, but that there is really marked variability across community rates of suicide here in Canada, and that these numbers should really not portray a singular picture of what Indigenous life looks like in Canada, while also not diminishing the importance of tackling the challenge of Indigenous suicide in Canada. And as a result, suicide risk assessment really is based on the opposite of this assumption that there's a generalized sort of approach to suicide risk assessment, and that there's a one size fits all, but that's something that we will get into, and that, you know, the approaching risk assessment within Indigenous context really needs to be recognize that diversity and variability. And so from the mainstream perspective, conceptualizations of suicide utilize a sort of biomedical model to understand suicidality, wherein the source of an eventual suicide begins and is located within a pathologized person or the disordered individual. And so further, suicide prevention practices embrace these concepts or these approaches and have really relied on this universalized one-fits-all approach that homogenizes the actual diverse needs of Indigenous people in Canada. And so in considering these critiques, and with growing advocacy from Indigenous health and critical studies scholars working with Indigenous communities, they have really laid the foundation to analyze Indigenous suicide as it intersects with contemporary social, structural, historical, and colonial factors. And so suicide risk assessment in that context should also respond to social, structural, historical, and cultural factors. And so as a result of this movement and into response to these shifts, the theoretical realm of suicide studies, this literature review sought to narrow in on the potentials of change within suicide risk assessment practices when we begin to consider these additional domains, for example, social or structural contexts, when responding to suicide and assessing risk within Indigenous communities. And so specifically, the following literature review will critically examine the standards of practice of suicide risk assessments that are currently being used by mental health professionals across the country, and look at what happens or what's been occurring when these practices are applied to Indigenous contexts or with Indigenous clients, and when they're being conducted by Indigenous peoples ourselves for our communities. And a heightened consideration will be given to understanding suicide risk assessment from Indigenous community perspectives. And so moving on, getting to the results of the literature review, there's essentially three groups or three sort of components that were pulled from the literature. The first is that we collated an overview of the dominant suicide risk assessment tools that are used here in Canada. We then dive into how risk and protective factors are relied upon within suicide risk assessment contexts. And then last, we consider the complexity of risk and consider gatekeeper training, which is one of the most prominent methods of intervening upon suicidality. Last, and just to provide some context about what's going on internationally, we look at different spaces across the world, such as Australia and New Zealand, and look to them as they have taken more steps forward in sort of developing their own tools and strategies for suicide risk assessment in their respective countries.
Okay, so I'm going to review here what suicide risk assessments are, just so that as a group we're on the same page. So suicide risk assessments are a standard of care, and this refers to what you are expected to do as a clinician when you suspect someone might be at risk of suicide. So typically this involves a process of information gathering, often in a checklist format with discrete yes/no variables that clinicians ask clients about. So for example, you might ask a client, are you having thoughts of suicide? Have you previously attempted suicide? And do you maintain methods for suicide, such as possession of firearms or medication that can be lethal when taken in large doses? It's recognized that these checklists are insufficient, and yet this is what is most commonly available and necessary to ask for. So when we ask these questions, we're not actually looking to predict if someone will die by suicide, because that's impossible. Instead, what we want to do is evaluate risk. And risk here refers to the likelihood that an event will happen. It is worth noting, however, that high probability of risk does not mean that someone or that a suicide will happen, and that low probability does not mean that a suicide will not happen. So as clinicians, we hope that by asking these questions, we can get an understanding about how imminent a suicide might be, and to determine if it's, a chronic issue, or to make decisions about how care and appropriate referrals can be provided. So when it comes to actually assessing risk, there are many risk assessment tools available. On this slide, we've chosen just to list 2 of the most common tools and trainings that are used, though, as I said, there are many, many, many more. So for the tools, these usually consist of a worksheet form that a clinician will systematically go through with a client, where, again, they ask a series of yes/no questions and come to determination about the level of risk. So for example, the Columbia Suicide Severity Rating Scales will ask questions like, have you had an interrupted suicide attempt? Have you had suicidal intent without a specific plan? Have you been feeling alone? Do you have a family history of suicide? And similarly, the Linehan Risk Assessment and Management Protocol asks similar questions to assess, manage, and document risk. As you can tell, as I list off some of these questions, these protocols are checklist oriented, and they do ask similar questions. So there are also trainings that are offered that seek to support clinicians and lay folk who may have conversations with people that they feel might be at risk of suicide. So, a really common one being Safe Talk or Assist by LivingWorks. They're useful in that they provide language and skills for having difficult conversations. So while Safe Talk seeks to help people identify suicidal behavior and ask difficult questions, Assist training teaches their trainees to evaluate the level of risk and then connect them with a clinician. So as examples, you can see on the slide, Safe Talk focuses on really getting people comfortable with asking the question, hey, are you having thoughts of suicide? Whereas Assist will get into a little bit more of the evaluative piece to determine, what level of care might be necessary. These trainings are limited though, in that their ultimate goal is to support someone at risk get connected to a clinician. And this is a problem if you are the clinician and you are trained on these models. The problem here being is that if you are the end of the line of support, what happens next? Okay. So it's worth noting that courses on suicide risk assessment are scarce, and there seems to be a tension on who should be teaching these courses, whether that be the training institution for mental health trainees or their practicum sites where they learn to apply their skills. So this said, many trainees actually do not receive adequate training on conducting suicide risk assessments, or even just really navigating these conversations in a way that feels comfortable. And in the absence of this training, there's a problem with relying on these assessment tools, especially when working with Indigenous communities. So the checklist approach to evaluating if someone is at risk of dying by suicide paints a picture of suicide being a product of individual struggle or pathology. And it ultimately promotes a universalization of suicide prevention that many Indigenous scholars have cautioned against. So as mentioned, these tools do not evaluate the ecological contexts that contribute to distress, including the social, political, cultural, environmental, and structural context that Shanna spoke about. And in the absence of accounting for these factors, as clinicians, we can promote a view that Indigenous populations are risky.
So in general, when it comes to suicide risk assessment, one of the common things that came up in the literature is the concept of risk and protective factors. So as many of you may already know, risk factors refers something that is said to increase the likelihood of an adverse outcome. In the case of suicide, this refers to things that make someone more vulnerable to suicide. So in general, there have been several risk factors identified, and while not an exhaustive list, some of the highly researched risk factors include things such as psychiatric illness, substance use, past suicide attempts, the presence of suicide ideation related behavior, and the list goes on and on. And then for Indigenous peoples, and specifically Indigenous youth in Canada, risk factors for suicide include things such as addictions, previous attempts, family history or community legacy of suicide, social isolation, racism, rejection, bullying, problems in school, abuse, lateral violence, mental illness, conflict with the law, poverty and unemployment, breakdown and or loss of cultural values and belief systems, accumulation of trauma and intergenerational trauma, extreme interpersonal conflict or the loss of a major relationship, dislocation from the land, barriers to accessing healthcare, especially mental health and substance abuse treatment, and rapid culture change. And although there are psycho-centric factors identified in this list related to Indigenous peoples and risk for suicide, like things such as addictions and mental illness, this Indigenous specific list also includes structural risk factors, which we'll see is not reflective, and this context is not utilized within the current approaches to suicide risk assessment, things such as poverty and unemployment and barriers to accessing healthcare, which is extremely problematic. So then on the other hand, protective factors are for things that make it less likely that an adverse health outcome will occur. So in the context of suicide, protective factors make suicide a less likely occurrence. So again, in general, strongest protective factor that came up in the literature was social support, in particular, feeling responsible for family and children can act as a strong protective factor, as well as religious beliefs may also buffer against risk factors. So speaking about protective factors, again, specifically for Indigenous peoples, this includes recreation, physical activity, positive cultural identity, self-esteem, family attention, support and care, positive parental expectations, peer support, caring exhibited by other adults and community leaders, community self-determination, a high level of general problem solving skills and coping, good physical and mental health, access to appropriate housing, culturally relevant healthcare services, future orientation, direction and determination, positive attitudes towards school, good school performance, learning ability, emotional stability or regulation, internal locus of control, sense of meaning or coherence, having many reasons for living, and religion or spirituality. So when we talk about what is really protective for Indigenous peoples, we're talking about the biopsychosocial factors that buffer against the effects of intergenerational trauma, colonialism, and discrimination. I think this presents an opportunity to think about potential directions for suicide risk assessment when you see things like spirituality, community self-determination, and physical mental health as being protective for Indigenous peoples.
So yeah, just as Jordan was saying, suicide risk really needs to be in conversation with the ecological dimensions of living. And this includes, as we have said, cultural, social, political, environmental, and structural dimensions of life. So our literature review really made us wonder what this might look like. So for example, what would it mean for suicide risk assessments to consider if communities have clean drinking water, or if they have access to a high school on their reserve? Or even, things like if they have adequate housing. So, in large part, suicide risk assessments rely on psychocentric understandings of suicide and suicidality. So a major critique within suicide risk assessments is that risk and protective factors as it relates to Indigenous people are so individualistic in their conceptualizations, and they decontextualize the issue of suicide and place prevention practices within individualistic understandings of what communities need. So we need to understand what suicidal behavior means for people in their particular sociocultural context, and to really not presume a one-size-fits-all approach. So when we talk about prevention in Canada, this universalizing emphasis has resulted in profiling Indigenous people as a risky demographic within a population analysis of health with little understanding of the sociocultural context or sociocultural meanings of suicide and the traditions that happen around that. So we know that infrastructure failings that make life unlivable are often being responded to at an individual level. So all this said, when we think about someone at risk of suicide in the therapy room, we want to find ways to be considerate and accountable to this complexity.
Yeah, so just on this sort of piece around where we imagine where suicide risk assessment is kind of thought to occur in a continuum of care. In 2013, the Canadian government published the Aboriginal National Youth Suicide Prevention Strategy, and in it talked about various contexts of suicide prevention. If you look at this list, it sort of divides this into 3 primary, secondary, and tertiary prevention zones, along with knowledge development and translation. It's worth noting that that particular document, which is a national suicide prevention strategy, never once mentions specifically suicide risk assessment as a practice, but yet is a document concerned with a national strategy for suicide prevention. But what it does talk about in the context of primary prevention is the practice of gatekeeper training, which we're going to get into in a little bit in a moment, which is probably one of the most widely practiced forms of suicide prevention that is informed by assessments of risk, but that sort of attempts to broaden the scope and the stakeholders involved in identifying risk within context of community. And then the secondary prevention space is one of the outcomes being increased numbers of referrals to appropriate resources, including clinical and non-clinical services and communities. So we really see suicide risk assessment practices really occurring for those of you who work in terms of healthcare systems within primary and secondary prevention spaces. You know, one result is that with appropriate intervention and early detection of risk, there's a kind of referral of individuals through to relevant services. This is a very idealized view of how healthcare services happen in many communities, but nonetheless, this is sort of the idea. And then at the level of primary prevention, a kind of health promotion perspective where you're widening the base of sort of attention in the community to increase mental health and suicide prevention literacy, so that earlier detection of risk can be had. I think what's really remains to be seen is that most of these forms of primary, secondary, and tertiary prevention are yet to be occurring in the majority of First Nations across Canada, specifically.
So when we went to the literature, what we noticed was that outside of looking for tools, there was a lot of literature on something called gatekeeper training with Indigenous communities. So gatekeeper training teaches community members to identify individuals who are showing warning signs of suicide, to identify them, and then to help those individuals access the services that they may need. This approach is informed by the assumption that community members play an essential role in supporting those at risk of suicide and responds to Indigenous perspectives by maintaining expertise on care within the community. So in this way, gatekeeper training is both an intervention and a prevention program. And while it's not a risk assessment tool per se, it is one of the ways that suicide has been meaningfully intervened upon at the community level. So this said, you know, gatekeeper training is not without its limitations. How people are trained to gatekeep may be problematic. So similar to the tools and trainings we discussed previously, it operates under an assumption that there's a one-size-fits-all approach to crisis intervention and assessment. And as we have discussed, we should not assume that what works really well in one community can be generalized to another. A second limitation to gatekeeper training is that some believe it assumes that mental health care can be culture-free and therefore a benign response to a person's distress. Again, the assumption here being that suicide can be solved using standardized and decontextualized interventions that are delivered to communities. This is troubling that given what we know, that culture is an essential part of the healing process for Indigenous communities. And a final critique is that others believe that the content of gatekeeper training centers too much on psychological illness and risk factors through a Western lens that really might not be relevant to Indigenous communities. So we did come across an article that spoke about an alternative to gatekeeper training, and it's called CARES, and it's a program that took place in rural Alaska. And CARES stands for the Collaboration for At-Risk Engagement and Support. And here training prioritizes life promotion and empowers local people to assist community members prior to reaching a crisis, as well as supporting those who are currently experiencing suicidality. The content of this training is rooted in participant stories rather than solely being based in what we know about suicide. So sorry. Yeah, it's based in stories instead of positive understandings of distress. And this program honors healing outside of colonial ways of being and achieves this through collaboration, creativity, community gatherings, land-based activities, and activism. And you can see from the slide differences between CARES and typical gatekeeper training, some of the differences and how they approach the location of problems. So this program was developed with Indigenous leaders and community members instead of for them. And so it is really community specific. The CARES model attempts to address some of the limits of decontextualized and standardized approaches that characterize most gatekeeper training models.
Okay, so we've talked a lot about what we found sort of within the Canadian context and some of the limitations of that material. And so now I want to highlight some of what's been going on at the international level in terms of developing some more Indigenous specific suicide risk assessments. And so Australia and New Zealand have been really leading the way in this domain. Developing culturally relevant tools for risk assessment with Indigenous communities and also an array of strategies. And so for the first example, we have Australia with the Indigenous Network Suicide Intervention Skills Training Program. This is a gatekeeper training program. Its goal is to provide Indigenous community members with knowledge on suicide risk factors and how to connect those at risk with the proper support and services. But it has this extra layer in that it's a two-part training model. So the first part is a brief introductory course where participants learn about INSIST and get to know one another. This session has really been included to allow for participating responders to understand the purpose of the INSIST program. It's sort of an informal yarning session where responders will get to know each other and understand what is the next 2 days of training will entail. And so they acknowledge that talking about suicide may bring up upsetting feelings, that could bring up memories, tough emotions. And it's important for participants to be allowed to opt out of the training if they feel like they're not ready. Participants are also welcome to return to a later training session, and they'll be informed of their role in the community once they have this training, which is really to create safer communities. And so the second part of the INSIST training is providing the participants with in-depth knowledge on suicide, first aid skills, interventions to identify when people are at risk of suicide, and with information on how to assist people to keep them safe. And so though INSIST was developed for Indigenous peoples, it's based on existing suicide prevention models that have been shown to be harmful for Indigenous peoples. So in a study examining the effectiveness of INSIST and other gatekeeper training programs used in Indigenous communities in Australia, researchers found that these programs were not necessarily tailored to sort of the diverse needs of Indigenous communities. And so again, we have this recurring theme of the ineffectiveness of this sort of one size fits all approach, even when we try to maybe indigenize these sort of typical or prevalent models of suicide risk assessment. And so Indigenous peoples were really not consulted, I guess, in the specificities in the suicide risk assessment development. And so they found that they were not fully effective, nor sort of culturally relevant across communities, because it is hard to develop a tool or a model that will be, highly relevant to the diverse, and specific needs of each community. And so this research highlighted a lack of Indigenous appropriate programs that were really self-sustainable and practical, and points to a need for culturally relevant suicide prevention programs that really honor the diverse needs of individual communities. And so the next thing that I'd like to highlight here, in addition to their INSIST program, there are different screening tools that have been developed for Indigenous mental health purposes. So maybe not necessarily suicide risk assessment, but that's certainly a piece of this. And here, so this one is titled the Here and Now Aboriginal Assessment Tool, or HANA. It is a culturally appropriate, semi-structured interview that covers different aspects of social and emotional well-being. This includes suicide risk and self-harm. And so HANA can be used to screen for various mental health risk factors and to determine whether a referral should be made. And so you can see here on the right side that HANA actually takes a narrative approach. So there are prompting words for each domain that are listed. And the point is that the clinician makes space for the person who they're sort of assessing or having these dialogues with to provide a narrative or story, and even write their responses verbatim about sort of the challenges that they're experiencing. There's also the typical socio-demographic information, and it's given in an interview style.
So I'd like to spend a few minutes talking about the development of what most of the countries that are experiencing disproportionate rates of suicide among Indigenous populations have done in response since the 1980s, and that is Canada, the United States, New Zealand, and Australia. A very prominent practice in all of these contexts over the last few decades has been the development and multiple iterations of national suicide prevention strategies. There has been one developed in Australia. It's currently under redevelopment. It came out at around the same time as the last Canadian national suicide prevention strategy for Indigenous people came out in 2013. Similarly, New Zealand, Aotearoa, initially in 2019, began developing their strategy and is currently ongoing and under revision and evaluation. And then presently in Canada, we have seen in the last few years a shift away from a national approach to suicide prevention strategies towards a distinction-based approach to Indigenous suicide prevention strategies, led by major advocacy groups and political organizations like ITK, like AFN, and other regional groups as well. So these strategy documents are very interesting to look at. We can just look at the next one as well. There's a few of them that we've put in here. This is a national strategy that is at the population level for Canada, so all demographics. There have been a series of Indigenous specific ones, specifically the most recent in 2013, the National Aboriginal Youth Suicide Prevention Strategy. These are really important to just think about critically for a moment, because a lot of time and money and effort goes into these strategies. But over the course of multiple decades now in Canada with these strategies, we have actually not seen the development really of any substantial advances in actual applied practice tools or practice developments. What they often have spoken to is the development of better prevention efforts, but accompanying those prevention efforts has not actually been the development of real actionable or applied resources. And so we're in the midst of sort of a new season where it's likely to be the case, and actually members of our network are deeply involved in the development of multiple new suicide prevention strategies. One of the things that we are hoping that our presentation today will kind of give pause to all of us for is to think really seriously about the need to develop resources and not necessarily only assessment tools and trainings, but things that have utility in the actual detection of risk. That's a really important thing to consider without at the same time necessarily becoming policing of that risk, but to better understand the nature of that risk when it occurs, and also to see these prevention strategies really begin to take on the challenge of how we might better assess structural concerns in the context of clinical and non-clinical risk assessment.
Now we're going to shift to some implications for practice. So as we mentioned a couple of times throughout the course of this presentation, there's this underlying assumption that there's this one size fits all approach to risk assessment, and this is not consistent with Indigenous worldviews. So as a result, there's an identified need for culturally safe suicide risk assessment practices among Indigenous people in Canada. Culturally safe care refers to the recognition of the role of culture in the conceptualizations of distress and well-being, placing value on understanding the particular meaning of suicidal behavior to the young person and their family, and exploring personal beliefs about suicide. Clinicians who are trained on culturally safe suicide risk assessment procedures for Indigenous people will require a good knowledge of their own positionality and social location, and an ability to articulate differing worldviews. This may be trained by Indigenous knowledge holders and community members, and this training must be recognized as an orientation to self and not as a threshold or competency to be met, as it's an ongoing process. So additionally, these practices must take into account the colonial history and trauma experienced by Indigenous peoples in Canada. They must challenge Western notions of suicide and suicide risk by taking a holistic approach to understanding Indigenous well-being. As an example, the medicine wheel, which is a part of certain First Nations epistemologies, understands well-being as the balance between the physical, mental, emotional, and spiritual aspects of being. Similarly, the Indigenous mental wellness framework uses these 4 domains to measure wellness through hope, belonging, meaning, and purpose. And throughout this framework, the definition of well-being shifts away from one that's deficit-focused towards one that's strengths-based and life-promoting. So additionally, mental well-being under this framework diverges from solely focusing on the individual towards a more collective and collaborative approach, including family, community, land-based, and non-human relationships. And then finally, professionals must be well-versed in the histories and social contexts of the individuals and the communities that they're working with in order to provide relevant and effective support. Both suicide risk assessment and cultural humility are 2 topics that scarcely receive formal training at institutions that educate mental health providers. When these topics are provided, it's usually a standalone lecture, guest speaker presentation, or embedded within the larger curriculum as a reading. And more problematic, these topics are rarely addressed together and are instead kept as separate topics, as if cultural humility and suicide risk assessment do not inform each other. And failure to attend to these topics in a more meaningful way continues to perpetuate harm within Indigenous communities.
My earbuds just died as I was talking. So everybody can hear me? Yeah, okay, great, okay. Yeah, the next thing we wanted to highlight was some of the implications of this work for research. One of the things that's very clear from our review is that conceptualizing risk is multidimensional. And while the majority of instrumentation and training programs around risk assessment have been exclusively and largely focused on biomedical factors and psychological symptoms, that is not the only established or clear dimension of risk. And so we need to think about the development of tools and ways that better account for multidimensional forms of risk. There's also very clear tensions that exist within the literature related to the difference between population level and community level risk assessment uses. So in some senses, when we think about the development of tools, we really, largely that happens on national and maybe at a better level on distinction-based sort of scales. But in reality, risk assessment and future research in risk assessment needs to be thinking in far more contextual terms. The other thing that we need to think a little bit more about is about how risk assessment tools account for distal factors and more complex factors within social determinants of health, and think about clinically useful ways of talking about those types of aspects of risk. it means conducting, and often in the context of suicide risk assessment, doing a much more thorough and detailed collection of information. With regards to actual assessment tools, programs, and instruments, what we see in the literature is mixed evidence, particularly in tools that have been quote unquote indigenized, that is taking a Western tool and trying to norm it within Indigenous populations. There's some mixed evidence. For example, in particular literature, ASSIST is a program which has very split evidence, where there are some examples of very successful utilization and integration within Indigenous contexts, and other contexts where, and other studies that have actually found potentially detrimental impacts of its use. So there is a need for ongoing evaluation. It does seem that the second piece that often gets missed is, in addition to culturally norming instrumentation, we have to have instruments that are called contextually reflective, that make sense in the context that we're asking those questions. And finally, what is clear from the existing literature, and particularly international examples of Indigenous wellness assessments, as well as suicide risk assessments, is that they need to attend specifically to cultural idioms of distress, looking at specific language that that is discernible, issues around spirituality, issues around broader relationality within communities, issues around meaning making, are largely absent from existing risk assessment tools, but that have been that are embedded in some of these other tools that show promise. The other thing that was very clear is that these tools need to be co-developed with communities, and I would maybe go further to say they need to be led by communities, which is one of the beautiful things about this NEIHR, is that it's led by Indigenous people, but that, you know, the most effective tools are tools that are developed in the context of communities. The other thing is that it's very clear that there's a direction in suicide risk assessment that actually inverts the project towards assessments of well-being and assessing risk in relationship to the presence or absence of resources necessary to promote Indigenous health and well-being. And so as such, our risk assessment tools actually need to shift towards wellness assessment tools, which help measure domains that are often missed and not captured within risk assessment, but that have substantial relevance and weight in relationship to suicidal risk.
Okay, so just to bring us to a bit of a close here. Now, among the many interventions that include social and structural responses conducting competent and culturally responsive suicide risk assessment remains really an underexplored and ill-established priority area relevant to Indigenous communities in Canada. So we talked about a few of the dominant reports that have been created in responding to suicide within Canada in both Indigenous and non-Indigenous contexts. And it's clear that, you know, developing suicide risk assessment tools and strategies has been a bit of a missed area. And so that is definitely a potential area to move forward in. Suicide risk assessment should really not only be relevant to Indigenous models of health, but are encouraged to move beyond ascertaining the proximity to suicidal death in hopes of preventing such death. So we want to see a place where suicide risk assessment is not solely ascertaining how close somebody is to suicide, but rather working towards for what Dr. Ansloos often calls life-activating conversations or dialogues with our clients or people in our lives that we care about, and how the work in this area should really embrace this possibility and pursue conversations and dialogue that move away from preventing death through towards activating life or igniting hope in the therapeutic and risk assessment context. So thank everybody for listening. I couldn't see the chat, but I was told that we are going to have time to respond to questions.
Yeah, we have a number of questions that have already come through, but we'll hand it over to our moderator, Dr. Stewart, to guide us through this conversation.
Would you like me to close the PowerPoint?
Sure, yeah. And you are on mute, Dr. Stewart, in 2022.
I wish I had a real life mute button on myself, to be honest with you, so I could, you know, think a little more deeply before I spoke. No, I just was saying I have so many questions myself, but I'm going to leave those to the end after we have an opportunity to respond to some of the questions. And the first question that I'm going to share with everyone is, I'll just read the question. And it says, I'm wondering if there is any literature that discusses or explores gatekeeping further with an Indigenous lens. We know there are healers and helpers being called to do this work, but agreed gatekeeping is not the best terminology or approach. I've heard people say they are on suicide watch, meaning they're working closely with someone who is at risk of suicide. There is little, if any, support for the healers, helpers doing this work, including when they lose someone to suicide and feel a strong sense of responsibility. Is there work being done to highlight this?
So I'll speak to that first, and then of course others in this group might want to add. So there are a couple of studies in Canada that have been recently published and that are underway that I'm aware of in BC that are looking specifically in partnership with PIAC and Health Canada at gatekeeper training and its effectiveness and some of the issues that are coming up around its application specific to Indigenous communities. I think you're right on the money. Using the language of gatekeeper in and of itself is very problematic. It highlights differential power dynamics in communities. It also is a term that is quite overlapping with policing and definitely reflects kind of a more surveillance-y approach to mental health, which I think is, in some ways not surprising and in other ways deeply problematic. So the question is that research occurring within the context of Indigenous communities and exploring different ways of speaking about this and different ways of conceptualizing this within Indigenous communities? The answer to that is yes. And one of the ways to think about that is really at the level of community health promotion, that every member of a community, elder, peer, teacher, youth worker, coach, bus driver, factory worker, that every member of a community has a responsibility and a role to take care and lift each other up. And so, some of the youth programs that we are directly partnered with in our lab really support peer education and also support groups of elders in helping them to feel better prepared to identify and to navigate these sorts of risks and experiences of suicidality as they might emerge in their engagement and work with community members. So that work is definitely happening. I think you raised a second point, though, which is really a critical issue that our network collectively and specifically within the theme is attempting to respond to, which is that the majority of mental health, and I would even go further and say crisis response and suicide specific response work that's occurring in communities across Canada, and I'll speak specifically in the context of First Nations communities, is occurring and is sort of resourced by people whose primary roles are not to be specialist mental health providers, but whose primary roles are largely to be community mental health promoters, educators. And so there is a huge issue for knowledge keepers and elders, for community mental health workers, for navigators, for social workers, psychiatric nurses, teachers. Everybody working within these community contexts is being tasked with doing very intensive, high-risk clinical work and is under-resourced to do so, and not just under-resourced to do so, but often under-supported. And so the types of supports that we see as necessary for this type of work is certainly continuing education, is certainly supervision and consultation, and is in the context of suicide prevention and risk assessment. We're actually in the midst of analyzing a national survey of all mental health providers within the NIHB program. And what I can say somewhat tentatively, we'll present the findings of that study to this NEIHR at a later date. But tentatively, what I can say is that our early results seem to be indicating that by and large, our providers within these systems, even providers with doctoral and master's degree education, have very minimal, if any, training in suicide risk assessment. So even some of the most qualified workforce to deliver mental health services and specialized risk assessment is woefully underprepared to do so, which is a huge collective risk that we need to be thinking about preventatively and thinking very actively about the development of supports. And those supports look like mentoring and education and continued care. And I think thinking about bringing elders and knowledge keepers into the context of that supportive mentorship, consultation, ongoing education, and resourcing is a part of that work, in addition to a number of spiritual and cultural components.
Excellent, thank you. I have another few questions. The next one says, thank you for a wonderful presentation. This is important work. I'd like your thoughts on current interventions like Talk for Healing and Hope for Wellness helplines. How can phone lines better integrate the implications you spoke about today?
So I'll speak to this a little bit. I'm also going to ask Jordan and Nicole to speak to this, because the three of us have been working on a study that's gone over the last year that has been independently evaluating the training experience as well as perceived efficacy, as well as some of the attitudes and beliefs and biases and perspectives of providers who are engaged in telephone-based Indigenous suicide and crisis support lines. And we've learned some really interesting things so far. Some of the things that are really clear is that there is, in the absence of sort of very clearly defined national and maybe regional and or regulatory standards for these lines, there seems to be quite an unclear set of practices in terms of what people actually do when they're encountering these types of risks. So one of the immediate things we can say is that there needs to be a more maybe clearly established sense of what baseline best practices in suicide risk assessment might look like for the training standards for folks involved in these lines. I will say that the two the lines that were referenced specifically to Hope for Wellness lines and Talk for Healing lines, Hope for Wellness is a really interesting one because it's offered in Indigenous languages in communities, and it's offered through telephone and or internet-based supports. These are private contracting organizations that are operating outside of any publicly available information related to regulation. So for example, to provide mental health services in Ontario, unless you're operating at a peer support line or a crisis line run by volunteers or non-clinical staff, there's really no publicly available information about the regulatory standards involved in the delivery of those services. What they talk about are having qualified people to take those calls, but very little is known publicly about who the consulting agency, Donnacona, actually partners with and who those providers are. We know a number of them, incidentally through the research, but I think one of the things I would say is that, and I know that this work is beginning because I have colleagues at KMH who are involved in some of it, who are connected to our NEIHR, but broadly speaking, there's a real need for evaluation across the board in terms of one, the efficacy of these phone lines in their prevention efforts. One of the big concerns that's emerging for Indigenous communities in relationship to these lines is that these response lines are also increasingly connected to policing, and so emergency services are ideally who you would maybe dispatch in the context of a phone call with somebody who is imminently at risk for suicide. But contacting emergency services for many Indigenous communities, if that first line of response ends up being a police officer or somebody who would then involve policing, can be very quickly escalating into an unsafe situation, and one that has very particularly racializing impacts or effects. And so, yeah, I think overall, I'm not going to say that based on what we're seeing in our research so far, that there's no value to these lines. But what I would say is that there's tremendous inconsistency. I think we have about 40 to 50 different crisis response lines that we've involved in our study, and that specifically service Indigenous communities, and that there's great inconsistency and variability in the experience, in the training level, and in the qualifications of people delivering those services. And by and large, their questions reflect, the questions that they might ask in the context of assessment reflect a fairly, I would call crude understanding of risk, but actually reflect a very, a similar understanding of risk that's reflected in the earlier risk assessment questions. Do you have a plan? Do you have access to immediate weapons and so forth to do so? They're very much geared towards that type of level of risk mitigation. But we should evaluate them. They may be a resource. I think that the government of Canada seems to give these contracts to largely private organizations and corporate consultancies, which I think is an interesting approach when instead they could invest in the development of a much more substantial public system. In investing in a public system, we would have greater accountability about the quality of services that First Nations, Inuit, and Métis receive in their engagement and encountering of these helplines. So that's my perspective. But Jordan and Nicole, do you want to weigh in at all on that?
Sure. Yeah. So again, we're not presenting on the crisis line survey here, but there are some interesting findings. So speaking to the point about, you know, what are the implications for phone lines and how can it be integrated with some of the things we spoke about today. In our survey, you know, we had largely asked people to comment on the extent to which they feel comfortable conducting suicide risk assessments. And we found that largely people overreported their comfortability with evaluating callers, saying that I can identify signs of suicide or risk factors, and I feel comfortable interjecting or intervening when these come up. However, we also asked people about some of the key issues impacting Indigenous communities and their awareness of them. So, you know, we looked at Indian residential schools, the 60s Scoop, the child welfare movement, Indigenous asylums in Canada, which seem to be less well known. And we found that people actually underreported their familiarity with these key issues. So I think the question there is, can you do an accurate suicide risk assessment and not know and be able to describe the impacts of these key historical events that are present and ongoing?
Jordan, do you want to add anything?
No, I think you pretty much covered it all. Similar to NIHB, I think we're just seeing a lot of issues around the cultural awareness that definitely will need to be reevaluated going forward.
Yeah, so this is where I think the activities of our network really link together. Those of you who were able to hear Dr. Mashford-Pringle's presentation earlier this week, talked about the central importance of cultural humility and cultural safety. And I think as Jordan and Nicole have both raised in this crisis response survey, one of the implications is certainly that crisis lines, these telephone lines, Hope for Wellness lines and so forth, just because a line can deliver a service in a language doesn't actually necessarily mean that line is going to be culturally safe. And so we need to think really not just about checklists of, oh, there's an Indigenous person, or, oh yeah, it's got an Indigenous translation of the DSM, but does it actually reflect Indigenous culture and development in the context of communities? Just because an Indigenous business owner can get a contract with the federal government to deliver a crisis line doesn't actually mean the practices of suicide risk assessment that crisis line is delivering in Indigenous communities actually reflects community development. And I think, I think Dr. Stewart might want to take us to another question, but I think there was actually a question related to this sort of.
Yeah, there's another question, and that's also about something very clinical and frontline, which so the person says, so many of my students have suicidal ideations and cut consistently. How do we use these strategies to help my lodge counselors be aware of the level of suicide risk when assessing situations?
Mm-hmm.
That's kind of a difficult question to answer.
Sure. Well, I guess on the front end, I mean, I think in any context where we're working with young people, Indigenous young people, our counselors need to be well supported with continuing education related to supporting young people who may be engaged in self-harming behaviors, and to have a better understanding and opportunity to learn a little bit more about what might be going on in, if we had a longer time today, I would talk about how generally there's a problem in the mental health field where people are deeply afraid of having conversations with people who are thinking about suicide, that the topic sort of results in a very big knee-jerk reaction where we get very afraid. And so one of the things I would say is, really normalizing and really making almost commonplace with your counselors and within a community context, how important talking openly about suicide actually is. Doing that in culturally appropriate ways, doing that mindful of doing that in a trauma-informed way, but nonetheless, doing it in a way that destigmatizes the topic so that we actually become much more familiar and more conversant with the range of experiences that young people have with suicidal thoughts, and that just because somebody's having a suicidal thought doesn't necessarily mean that that puts them at risk, or puts them more at risk than somebody who's maybe using substances or somebody who's gone through a very traumatic event. Would checklists be valuable tools for them? I think what would be more valuable than a checklist is actually a training around mental health literacy. Learning to recognize when a young person might be struggling, learning when might be a good time to involve a supervisor, learning what might be a good moment to ask a young person some more questions when they say something to you that sounds maybe worrying. Those sorts of things to me are actually maybe more effective than just like if they say this, ask this, this, and this, because those moments can be so dynamic and so hard to anticipate. And I know that the challenge is that like devoting time to training, devoting resources to training is not a simple task. And I know that it's also a resource demanding task. And so I don't want to at all make it sound like the person who asked this question, Kay, that it's an easy thing to do. But I do think that the more long-term benefit is actually is helping to support and invest in your team's capacity to recognize and to respond to sort of various types of mental health emergencies or concerns. And also to not underestimate the power of peers in helping to ignite life-activating and hopeful conversations. A lot of times when people talk about suicide, it's because they want support. They want to feel uplifted by the people they're speaking to, or they trust the people that they're speaking to, and they feel like they can be open and honest with their feelings. And when we train people to sort of immediately switch into a checklist mode, it really diminishes the quality of that conversation. And so helping people learn about when those conversations should involve other people, or what types of questions might help increase a person's hope. Those are the types of trainings and areas that I would say are more prudent to invest in at this stage.
Thank you for responding to those. And, listening to the presentation and then the questions, what I'm really noticing is that that there's a lot of people, in Canada who work with populations, including our people, who have issues around suicidality and self-harm, yet the clinicians or maybe some of the groups of service providers are still sort of wondering, like, how do we deal with this both systemically, which is, a big issue I think that we're all grappling with, but also like on an individual intervention basis. How am I going to deal with this? Despite the veritable plethora of tools and assessments that are available. And I think to comment just as a listener on what you're saying, what I'm hearing you say, Jeffrey, is that checklists and assessments are really actually tools that are only as useful as the person who's able to provide the interpretation of them.
Absolutely.
So they don't really have any value in and of themselves. It's the power of them is in the clinical interpretation of them and the application of the results, not the tool itself.
One thing I would maybe respond with that to say, Suzanne, is that I would maybe go one step further to say, when we're using these tools largely as a means to safeguard organizations away from liability for suicide, they tend to take on a kind of a very formulaic and often ineffective use. So here is the checklist so that we have a suicide prevention policy in place is going to be a far less effective use of a tool than somebody who feels prepared to have a meaningful conversation with somebody that might be suicidal. And that conversation, of course, is going to involve questions that assess the levels of imminent threat or risk of self-harm. But if that's all that we're doing, we're just turning our professions and our roles into policing. Instead, what we can do is we can have much more skillful conversations about hope and about inspiring people's ability and sense of capacity to keep living. But that, I think, to your point, requires really good training and support, which, going back to a question that was raised in the other chat, which I think is maybe why these national strategy documents keep getting created, is in and of themselves, they're not effective and they're not reducing the rates of suicide. But what they tend to do, and what I think why they keep happening, is that I do think they help lobby government support of funding for things like training. What we have to be really mindful of and I think critical of is following the money to actually see if it leads to that. Yeah, I mean, I think that's yet to be seen. But what's really clear to us is that there is a major training gap, even among qualified professionals, to do quality risk assessment.
Yeah, absolutely. And I think this is a really important conversation to have. And it's even more important that the recommendations of your study and your work are reaching the ears and the desks of the people who have the influence to make the changes for this that are required in order to make that systemic push that we need to have happen that will alleviate some of these challenges that are happening on the frontline levels. So are we ready to close off then?
I think so, yeah.
Okay, well, I'm going to say a huge thank you from my heart to you, Dr. Ansloos, and to Nicole, Jordan, and Shanna for being here today and sharing this very critically important work with all of us, and to Roy Strebel, the Ontario NEIHR coordinator, for the technical support and ongoing cheerfulness and positivity that he brings to all of the work that we do, as well as to say a big thank you to all of the participants, the audience members who came to be with us today. And please, that I ask all of you again to fill out the feedback form that Roy had posted in the chat, so that we can keep a record of what we're doing well and what we can change to keep doing even better to meet everybody's needs. And as well, to let you know that Roy will be editing the recorded presentation and placing it on the Ontario NEIHR website, where you can rewatch it at any time at your convenience. You know, if you have nothing to do on a Saturday morning or a Friday night or a Sunday evening, you can go and watch some of the archived NEIHR webinars, and we have some great ones there. So Masi Cho, thank you so much on behalf of the Ontario NEIHR and the Wakabiness Bryce Institute for Indigenous Health at the University of Toronto. Miigwech, and have a wonderful weekend, everyone.
Thank you, Miigwech.